periodontal tissue destruction. There is some direct effect of the bacteria on the tissues. The bacteria do release enzymes and toxins that cause tissue breakdown, but this is a minor effect. The indirect pathway to periodontal disease is causing most of the damage. It is due to the body's reaction to the bacteria in the circulatory system. So while the bacteria initiates periodontal disease, the destruction of the periodontal tissues is really due to the host response to the invading bacteria. C-reactive protein, or CRP. It is produced by the liver in response to injury, inflammation, or infection as part of the normal immune system response. CRP is an attractor of the inflammatory mediators. So, for example, if we had a splinter on our finger or in the presence of gum disease, CRP is produced by the liver, and it will go to the finger or the gums and attract those mediators necessary to fight off the injury, the inflammation, or infection. It is a blood vessel inflamer. It participates in the development of clots and plaques. All recent evidence supports the role for CRP in atherosclerosis. It is a blood marker used to assess inflammation and cardiovascular risk. What evidence exists for the mouth-body connection? Let us first review what we've discussed so far. We start with dental plaque, a biofilm composed of millions of bacteria. These bacteria come in contact with the ulcerated pocket epithelium during brushing and chewing most commonly. The bacteria enter the bloodstream and progress to a bacteremia. This triggers the inflammatory response to release inflammatory mediators and enzymes. The liver, in turn, produces CRP. All of this resulting in the tissue destruction that we see clinically in periodontal disease, along with the systemic and cardiovascular effects as a result of the inflammatory process. Let us now review some of the research. Periodontal pathogens and myocardial infarction. This study provides serological evidence that an infection caused by the periodontal pathogen P. gingivalis increases the risk for MI. Periodontal disease and atherosclerosis. In this study, two of the most pathogenic periodontal bacteria, A. actinomycetum comatans and P. gingivalis, get into the circulatory system and become embedded in the fatty atherosclerotic plaque, remaining alive and invasive. Periodontal disease and coronary artery disease. In this study, it was found that those people with greater amounts of the urobacteria that cause periodontal disease had slightly thicker carotid arteries. A thickened carotid artery indicates a buildup of plaque, which is associated with an increased risk of cardiovascular disease and stroke. This was the first study to show a direct link between cardiovascular disease and the bacteria responsible for periodontal disease. Periodontal disease and pregnancy. Women with high levels of CRP have a 7 to 8 times greater risk of a heart attack or stroke compared to women with low CRP levels. Mechanism of action believed to be the inflammatory mediators, such as tissue necrosis factor alpha, interleukin-1, matrix metalloproteinases, crossing the placenta, exposing the fetus to infection and toxicity. In another study, it was found that women with untreated periodontal disease have a 79% higher chance of premature childbirth. Treatment gives an 84% reduction in premature births. periodontal disease and respiratory disease, respiratory conditions such as pneumonia, COPD or chronic obstructive pulmonary disease, such as emphysema and chronic bronchitis. Mechanism of action believed to be the inhalation or aspiration of bacteria from the oral cavity into the lungs. This would be an example of a direct periosystemic link. Periodontal disease and cancer risk. A May 2008 study included more than 48,000 male healthcare workers. When compared to men with healthy gums, the men with a history of gum disease were 14% more likely to develop cancer overall, 30% more likely to develop blood cancers, including leukemia, multiple myeloma, and non-Hodgkin lymphoma, 49% more likely to develop kidney cancer, 54% more likely to develop pancreatic cancer. Possible mechanism of action in the case of pancreatic cancer is patients with periodontal disease and poor oral hygiene have elevated levels of oral bacteria and much higher levels of nitrosamine due to the nitrate-reducing bacteria in the mouth. Nitrosamines, gastric acidity, and inflammation are believed to play an important role in pancreatic cancer. Periodontal disease and diabetes share a bidirectional relationship. Everyone is at risk of developing periodontal disease, but people with diabetes, regardless of age or type, are more susceptible. People with diabetes have more sugar in the mouth, which provides a great environment for bacteria to thrive. They also have dry mouth as a result of reduced saliva, subsequent to medications or neuropathy. Diabetic patients are 2.8 to 3.4 times more likely to have periodontal disease. High and fluctuating blood glucose may increase the risk of periodontal disease. Periodontal disease, in turn, affects blood sugar control, lengthens the duration of diabetic symptoms, and speeds the transition from prediabetes to diabetes. It is a vicious cycle. Some facts on diabetes. It is an epidemic. There are over 24 million diabetics and over 57 million pre-diabetics in this country, and most of these will become diabetics in the next 10 years. According to the CDC, Americans born after the year 2000 will have a 1 in 3 chance of developing diabetes during their lifetime. It is the 6th leading cause of death in the United States. 65% of adult diabetics will die from heart disease. It is the #1 cause of renal failure, adult blindness, and lower limb amputation not related to trauma.